my name is Soaz. I'm a third-year pharmacy student at Manchester, and I'm also currently the Pennine Area Coordinator for the BPSA. And this webinar Wednesday will be about pharmacists and policymaking, as the title intends, and it's just so it can introduce you more into what policymaking is and like how your degrees, like as a pharmacist, your degree is actually quite malleable and you can go into many different routes, career routes. You don't need to just go into community, hospital. You've got many other choices, and both speakers tonight are also currently like pharmacists themselves, and they're also in policymaking. You know, they're still like registered with the GPHC. So I'm hoping by the end of tonight, you guys learn more about what policymaking is and how, if you're interested, you can have an influence in changing policies for pharmacy and for the healthcare world. So starting will be Ellen. She will talk about her role as a researcher and how that influences policies. I'll leave it to you, Ellen.
Yeah, let's just hope I can get the technology to work. I'll do my best. So I'll try and share my screen now. Okay, can you tell me when you can see it? Because I know it takes a bit of time to come through.
Yeah, I can see it.
Yep. Okay. So I'm going to talk for hopefully about 20-25 minutes so that there will be some time at the end for questions and for discussion. If the presentation turns out a bit longer, then I'll just skip at the end and just go over, because I don't want to talk for too long. So as Sol said, I work at the University of Manchester, where I teach pharmacy law and regulation, which obviously all the students come skipping into my lectures with excitement. So I'm going to talk about something slightly different today. So I just thought I'll say a little bit about policy, my background, so you can relate to why I'm talking to you. And obviously I look back over a reasonably long career already, but I'll start back to when I started. And then really I want to give you some examples of my research and how that relates to policy, because really that is why I do the job I do, apart from the teaching bit, but on the research side. So what's policy? Well, kind of policy is all around us, and policy can be regulations, but policy in particular around healthcare are the various documents, policy documents that come out that inform and guide how we practice in the whole health service, but in particular also in pharmacy. So regulations are probably a bit more tightly knit, but actually somebody still needs to implement them and put them into practice. So policy, whilst it's one word, is actually quite a broad area. So my background is a pharmacist. When you asked earlier about where did you qualify, I qualified in Germany. So I went to University in Bonn quite a long time ago. And then I came to Manchester for a year to do an MSc in clinical pharmacy. And that really set me up in terms of interest and what I'm doing now. And basically the examples that I'm going to choose are picked over time, starting with the early work, which I started really when I was doing my MSc and then carried on a bit longer, which was over actually a period of 10 years looking at prescription charges and the impact of charges on patients and whether they take their medicines or not and the kind of choices they make. Then I want to talk a bit about pharmacy services and some of the work we've done around informing them, talk about workforce, pick the example of revalidation, which we have now in place, and then actually end with what probably is most of interest to you at this stage in your career, which is around pharmacy education and actually how that's changing at the moment. There are some significant changes afoot here. So as I said, I started, and so I'm starting with my MSc when I first came to Manchester, and that is quite a long time ago, and you're all quite used to now that we've got a lot of over-the-counter medicines at our disposal as P medicines, and actually quite a few of them have gone to general sale as well. But actually, when I did my MSc, it was really quite new to move medicines from prescription-only status over to become P-medicines to be available for people to buy. So my MSc was one of a number of small early studies looking at, well, actually, why would somebody go and get a prescription when they can buy it over the counter now? And convenience came out of that quite strongly. But one of the things that came through was that people chose on the basis of cost. Because actually, if you have to pay prescription charges, then buying an over-the-counter medicine probably is cheaper than the charge, which is quite high and actually has continued to increase since then. But actually, if you're exempt from prescription charges, and quite a lot of people are in the UK, or in England actually now, then it can be much cheaper to go to the doctor, get a prescription, because you won't have to pay anything for your over-the-counter or self-medicine. So that meant that actually there's a real barrier for people, or there was at the time. And colleagues of mine then built on this research and did what was called the Care at the Chemist project. And really that was about removing that barrier, allowing pharmacists to give medication actually for that to be paid by the NHS P-medicines. And you all go, oh yeah, we know that's the minor ailment service. Well, at the time, and we are talking, you can see the dates in the bottom there, that's quite a long time. This informed what we all know as a minor ailment service. So looking at it from the other side, you could say, well, actually, impact of prescription charges when people do have to pay. And actually, I ended up doing quite a lot of research in the first 10 years of my career, looking at the impact of prescription charges, or what's called as co-payment, in other countries. And we started with a European project looking across 6 countries and recruiting patients with 4 different conditions here, some with an option of over-the-counter medicines, and HRT actually, because we've got that odd thing of a double prescription charge for those who have to pay charges. And I built on that further, got a postdoctoral fellowship, so in the middle, in between somewhere there, I did a PhD, so I'm now at postdoc level, and looked at patients with asthma. And obviously these are all projects going over a number of years, and I'm summarizing really into the headline findings. So cost, as you can imagine, for those people that had to pay for their prescriptions had an impact, and affordability came into it. And whilst this work goes back quite a long time, you can see the discussions around prescription charges popping up regularly, especially recently, obviously through COVID, but even before that, when with austerity and people who are kind of just going over the income level where they have to pay charges, but actually have to make decisions about, well, do I pay shoes for my child, or am I able to pay for the medication that I need? So there's a whole range of strategies that people use to manage the cost and be able to afford their medication. And obviously in England, we've got something called a prepayment certificate, which you will hopefully, or many of you will be aware of, which is intended to help people who are lots and lots of medicines to afford that, and basically have a one-off charge and then be covered, in effect, by exemption from prescription charges. But actually, if you haven't got an awful lot of money, then having enough money to pay for this in advance really posed significant problems for the most vulnerable people. As part of this, I also did some work looking at reviews of prescription charges. I don't really want to go into too much detail around that, but generally people are very supportive of the NHS, and that hasn't really changed since then. Sorry, I'm trying to... Oh dear. Sorry, I've just been thrown out of my internet. I'm assuming you can, this is normal, I think, because the university resets itself and then I have to log back in. So I'm gonna unshare my screen for a minute. I'm gonna have to log back onto my system. Sorry.
Yeah, I mean, I guess that's tech issues are all new to the tech here. It's perfectly fine.
I'm sorry about this. I forgot that that happens in the evening, that the system throws me out of the university computer.
Must be a real pain if when you're working late and then, you know.
Well, it just disconnects my work computer. That's all it does. But it just throws me out. So it'll still be open when I manage to get back into it at the moment. Right, I will now share my screen again, if I can work that out.
I feel like this is every student's dream, just a perfect excuse like, oh, my internet just threw me out. I can't log in.
Yeah, and that it actually really does happen. Oh, I need to do that as well. Oh. I think I'm fully back on now. Can you see the screen again?
Yeah.
Brilliant. Sorry about this. So I was talking to you about the project I did for my postdoc. So I'm now coming to policy. So actually at that time, you can see by the date here, and I've given you really headline findings at the time. There was a call, there was a review by the UK government, Health Select Committee, and you hear that terminology occasionally still. It still exists, this Health Select Committee, and they were doing a review of all health charges. And of course, prescription charges are one lot of charges. There's a whole load of other charges, such as even including charges people have to pay to actually get into the car parks at hospitals. So it incorporated all of this. And based on the research that we've done, and I was working particularly closely with Professor Peter Noyce, who was Professor of Pharmacy Practice at the University of Manchester, and we submitted quite detailed evidence to this Health Select Committee, and I was subsequently invited to give oral evidence to them, and was invited. And actually there was some further review, and I was specifically invited to them to present to them in 2009 when they were particularly interested in prescription charges for people with long-term conditions. And actually not as much has changed really as could have done. Not the prescription charges model in this country isn't all that perfect. But actually there was some changes made at the time. Prepayment certificates at the time were actually for 4 or 12 months. And based on the research that I've done saying, well, actually people can't afford that outlay, they reduced the length of time to 3 months, and they actually brought the cost for those prepayment certificates down gradually. They also exempted an additional long-term condition of cancer. They didn't make that many other changes, and they certainly didn't reduce the cost, but actually England is now the only country left that charges prescription charges. The other countries, the time when we did the study, did still have charges, but actually they don't anymore. It's just England. So actually that was the first 10 years, and then I did a number, I became part of the Centre for Pharmacy Workforce Studies. And as that tells you, we do research looking at the pharmacy workforce, and we've done quite a lot, and I'm only going to pull out some examples and looking at my time, I might have to skip some so I don't go on too much. So we've done early register analysis, looking at careers, career intentions. Why do you actually become a pharmacist? Why do some pharmacists leave the profession? That kind of thing. And like I mentioned earlier, we did some work on pharmacy revalidation. We also have done a lot of work informing community pharmacy services. So if you think before the community pharmacy contract that in 2005, we've now had a new one in 2019, but the big change, the first big change happened in 2005, when up until which point pharmacists were really mainly paid per item of what they dispensed. So really there was no funding for any kind of extended services or services going to more clinical. So we've done quite a bit of research informing those early services, what they were, and I mentioned the minor ailment service earlier as well. And more recently, we've done quite a large study looking at, well, actually, you know, for example, MURs have had a bit of bad press, not entirely unfounded, in that people were going for the easy options and doing easy MURs and not necessarily those ones which would benefit patients. So we did some work looking at, well, what actually defines and drives the quantity of services versus actually making sure that we have quality of services. And when you have a payment system which reimburses per item fees, then actually that doesn't incentivize quality, which tends to take a little bit longer. And actually what's happening now is that under the new community pharmacy contract, we've got this PQS quality, pharmacy quality scheme, where pharmacists have some early attempt at actually incentivizing higher quality services in community pharmacy. We also did some work around skill mix, because actually what is really, really important if you want to deliver good services is that you have the whole team working together. And relating to that, obviously you need the pharmacy education to underpin that. So revalidation, in my lectures I always use a picture of Harold Shipman, because it's his fault that you've got to learn even more about regulation of medicines, in particular around controlled drugs. But actually Harold Shipman in many ways is also responsible for the fact that we now have revalidation, because after Harold Shipman, if you don't know who he was a doctor who worked as a GP, not all that far away from Manchester, and he was convicted of killing over 200 people over about a 20-year period. And actually, of course, you know, we don't want another Harold Shipman. And after that, reviews and looking at, there was a white paper published and said, well, how can we make sure that we don't have another Harold Shipman? And that was really implemented very quickly for doctors and for dentists. And pharmacy was a little bit behind, but that was actually turned out really well for pharmacy, because we could look at what doctors and dentists were doing and then had a bit more time to work on a model that would suit pharmacists and pharmacy technicians in their revalidation, to ensure the public that pharmacists continued to be fit to practice. So doctors were implementing a model of using appraisals. So doctors undergo annual appraisals, and every 5 years there's a review which includes those appraisals to then revalidate. There's other things that are being looked at as well. The dentists went much more of a CPD model of continuing professional development. So we were commissioned by the GPAC, by the General Pharmaceutical Council, the regulator for pharmacy professionals, as you hopefully all know, to look at those two models that were in use for doctors and dentists, and to see how they would fit pharmacy. And we specifically focused on appraisals and also other potential sources of evidence that could feed into revalidation for pharmacists. And again, I'm giving you some headline findings. We spoke to and we did a survey and did interviews with people in all sectors, and pharmacy obviously have people working not just in community and hospital pharmacy and patient-facing sectors, but in a range of other sectors. So we found that appraisals were generally used in all managed sectors, and that includes universities, for example, where I work. I have an annual appraisal, but actually they're lacking for some people. So people who are owners or people who work as locums who don't fall under management structure, if you introduce a system of using appraisals for revalidation, you have a group of people who wouldn't actually be captured there. Then there were questions around, well, who actually does the appraisal? It's a line manager, and a line manager wasn't necessarily a pharmacy professional. So in my case, for example, if you're looking at teaching or research, there's not necessarily a reason why my appraisal should be done by another pharmacist who understands the needs in terms of revalidation. And then there was also an emphasis on performance, and performance depended on the sector within which you were working. So in academia, my performance is about that I get good student feedback, that I deliver good teaching, and actually that I publish, do good research, and that publish high quality research papers. In a community pharmacy, that focus wouldn't, so the people that were doing the appraisals said that actually we assume pharmacists can do their job, but actually what those appraisals were on things like targets, or for example, doing X number of MURs, achieving various things which were focused more on kind of a business model. So it depended, the focus of those depended on where people were working, and they were very often not really about ensuring continuing fitness to practice. So that led, that research led to me becoming part of the GPOC Revalidation Advisory Group, which worked over 5 years to actually come up with the system that hopefully you now know, and only those who kind of in the more advanced years will be familiar with what was in place before. So there's quite a lot of discussion around appraisals, and what you'll see in here is now the use of a peer discussion, which actually allows somebody to have a conversation with another pharmacy professional or somebody to help them reflect on their practice. And you, I'm sure all at your universities have got varying versions of this that you're doing even as students, so that you'll get familiar with this. So again, this is something where research informed policy, which is now absolutely in place. I'm conscious of time, so I'm actually going to skip this. If you're really excited about that nice picture that I've got there, then I can come back to it. But I'm going to move to talk a bit about pharmacy education, because there's actually lots and lots of activity around changes and policy direction, which is about pharmacists becoming much more clinical professionals, and actually not just pharmacists. We then need the support team around us to help us and take some of the more technical tasks off pharmacists. So we've actually done a range of studies looking at various points of education. So this starts with the M-Pharm, and then after the M-Pharm, in most cases that's not integrated. You actually complete your M-Pharm, you go into a year of pre-registration training. The terminology we hear more and more now is foundation when we talk about the early years of practice, and then advanced as you gain your independent prescribing qualification and you become a more advanced and experienced professional. We've also done some work with pharmacy technicians who do a 2-year qualification, work based with some kind of course learning either online or by attending a further education college. And I mention that because actually it's really important that pharmacists recognise what pharmacy technicians can do and they work well together, but also by some of the studies we've done, which are informing what's going on at the moment, there are quite a lot of parallels. So what I want to talk about here is a study that we did, well, actually that was one of my PhD students looking at the pre-registration year, that in next year or in the coming years, at some point when you finish your MPharm degrees, you will be going into your pre-registration year. And he looked at a number of trainees and also their tutors who trained in community pharmacy, wholly in community pharmacy, so the whole 12 months spent there, and also looked at a number of them who actually did that training in hospital. And what he found was that actually if you're in community pharmacy, as you would expect, you work in a much smaller team. There's very often just one pharmacist, that's your tutor. There's a number of support staff around you. You may have some contact with your local GP surgery. You'll get familiar with a range of services, the more common medicines in primary care, obviously very exposed to over-the-counter. But in terms of learning and being able to use that time to really consolidate what you've learned in your MPharm and apply all of that knowledge that you've gained to practice, there was relatively little time given to students to actually do that. They were there most of the time working pretty much as a member of staff. In hospital pharmacy, the teams were much larger. So there's the pharmacist pre-reg tutor, and then a whole load of other pharmacists and other pharmacy staff. And actually in rotations going on to wards and various other rotations, coming in contact with a whole much larger multidisciplinary team. So quite a different experience. It was much more about learning specialist medicines, but actually what was quite common in hospital pharmacy is that trainees got a dedicated study time, so that there were some of the time what we call supernumerate. So in community pharmacy, pretty much people were treated or worked as employees, as staff, as workers, whereas in hospital pharmacy, it was more of an apprenticeship type model where you're there to learn and by working the support to learn. And actually that was very similar, and that's why I mentioned the pharmacy technician study when we looked at work-based learning for pharmacy technicians before they register. Very similar. And actually you could say, well, does it matter? Well, actually, yeah, it does, because there is impact on the failure rate in the pre-reg exam, where hospital trainees tend to do better. And actually for pharmacy technicians, that was similar. So there's lots of relevant messages in here about what's happening at the moment, looking at pre-reg and MPharm training. We also did a study looking at foundation training, and the terminology here is changing in that pre-reg will soon be called foundation training. At the time, that was more looking at the early year or so after registration. And actually we looked again at hospital and particularly community pharmacy. Again, I'm conscious of time, so I'm not going to go into detail. I can come back to it if you want to ask me about it at the end. So I'll just briefly want to mention the importance of us recognizing that pharmacists are becoming more clinical professionals. There's lots of policy around that and actually funding that's been made available to assist pharmacists in extending their skills. So looking beyond going post-registration. If you haven't heard of it, we have this pharmacy integration fund. Certainly in England, NHS England putting about £42 million into post-registration training where pharmacists could go, because hopefully you'll be aware that we don't just have community pharmacy and hospital pharmacy, but actually pharmacists need to work across a whole range of settings, and they're supposed to be much better integrated to help patients transfer between those settings. And really pharmacists need to have skills in all of those. So general practice surgeries, in urgent care settings, even in care homes. So this Pharmacy Integration Fund funded training to help them do that. It also funded independent prescribing qualifications for those. And there was also training for community pharmacists to do so that they would be able to learn additional skills and actually contribute more to clinical services in community pharmacy. And actually what we also evaluated was a cross-sector pre-registration programme where pre-registration trainees were placed in a GP surgery for at least 3 months of their training year, and the rest of the time they were either in community or hospital pharmacy. And actually, one of the things that becomes really central to this is the support that trainees gain during that time. And one of the things, and again, lots around policy and implementing that support, is having education supervisors and actually having practice-based supervisors who help the trainees at whichever stage they're at, and also recognising the importance of actually being able to work across sectors. And as I said, the GPHC has just brought out new standards for the initial training, educational training of pharmacy professionals, and there are lots of elements of kind of research that we've undertaken. I don't really think I'm going to say too much about this because I'm conscious of time, so this just summarises the key bits that I've been talking about. I could come back to them, but I really don't want to hog it for much longer. And I'll take questions now. And try and unshare my screen, I think. Stop share. Right.
So if anyone has any questions, or if you guys were curious about anything from Alan's presentation, now's your time to ask. I think one thing I am curious about personally is for a student, how can we get into like the policymaking like research? Because you spoke about like how a lot of your research had like a lot of impact in helping pharmacists, whether it's the killer GP or other like factors. But I'm just curious about like, so if I were interested to like go into like the research side, how would I do it? I think
okay. So obviously the kind of research I do is very applied and is very policy focused. So what interests me about doing research is making a difference and actually informing how the profession moves forward and how we can make sure that actually that's effective. That doesn't always work. Not everybody always takes note of the kind of research. So my focus is as a researcher as opposed to a policymaker. I inform people who make policy. And if you want to be a researcher, that means you have to do postgraduate qualifications. You need to do training. You start not uncommonly with a master's qualification, which gives you a good flavour of whether you actually like research, because research isn't for everybody. It was for me, so I went to do a PhD. Really, a PhD is your route into it's a PhD. A doctorate is about giving you the skills that you need to be able to work as a researcher, and then you kind of build on it from there. The postdoc fellowship, that kind of thing, isn't an absolute must, but a PhD is if you want to be a researcher, is pretty important.
I think Aditya also had his hand raised at some point.
Yeah, thanks for that, Ellen. That was a really good presentation. Really interesting to hear, like, the research side of policy making. I suppose some of the things you talked about. I mean, I remember them. I'm not saying I'm not. When I was doing my degree, between 2012 2016, some of them like the foundation program and do you want to upskill community pharmacy through the use of the clinical diploma, which, okay, I know the barriers and all that, but but a lot of this stuff has been talked about for quite a while. So in your experience, how long do you find, because especially the minor ailment, that shocked me actually, it's been on the cards for that long. So I suppose in your experience, what is the time lag, say, from inception of doing the research and building the evidence base to actually getting to becoming policy?
First of all, the evidence base doesn't necessarily mean that it becomes policy. It's sometimes post hoc, so it's also a bit of luck if somebody takes notice of the research that you do. But actually, we are talking several years. 10 years isn't unusual. It could be longer than 10 years. And actually, I think now we're getting much better engaging very early on with policymakers when we do the research, so that we work with them and we work with them to inform the questions that we're asking. So actually the research projects we do are relevant to them, and they actually answer the questions that they want answers to, rather than us going off and thinking, oh, that's really interesting. And so I think that engagement and talking to policymakers and being part of some of those advisory groups, for example, that is how you achieve that impact. Or when I put evidence into the Health Select Committee, that kind of thing. They wouldn't have known about it if I just said, but I've written these really, really good papers. They've been published in really high quality academic papers, because actually policy makers don't read them.
Thank you.
I think we're now starting to have questions. I think one of the questions is, what do you think about pharmacists not being more involved in the vaccination distribution? Does this have anything to do with policy?
Yeah, of course, that's got something to do with policy. And yes, pharmacists should be involved in vaccinations. And actually, if anything, they've really proven with the rollout of flu vaccinations that pharmacists can do it. That was a policy that went very, very quickly. And some of the earlier, in some work that we did, we looked at barriers, and some of the barriers were because GPs are paid to deliver a percentage under what we call QOF, the Quality Outcomes Framework. So they are paid for so many % of their patients must have the flu vaccine. Well, actually, then pharmacists came along and said, oh, we'll do that. And in the early days, that didn't count against their QOF measures, and they weren't very happy, because actually that meant they then potentially lost money. Once that got sorted out, they were more than happy to have pharmacists take that role on and actually contribute. So I would argue, they've shown that they can do it for flu vaccine. I think they can do it for COVID.
Interesting. So it's all about the money. And
But it's not all about the money, but actually it's got to be recognised that money plays a role, and actually that not only community pharmacists have a business element to them, that GPs in particular aren't just NHS employees.
Yeah, and I think we've got other questions coming. Another one says, do you need an MSc to get into like policy making after like a pharmacy degree? Because you did mention about like needing to do a master's too, or
no, I don't think so. In getting into advanced practice, what we might call advanced practice, isn't just advanced clinical practice. It's just going into an area that you're good at, which you hold a particular type of expertise in. And that doesn't have to be an actual qualification at MSc level or beyond. They are important in academic terms, and if you want to go into a research career, you can get that that expertise and experience in all sorts of ways. And I don't think there's anywhere that says you have to have an MSc.
Oh, that's interesting. Thank you. And I think this is another one. It's quite interesting. They're saying that they have like having some experience in policy. Is there any possibility to get more involved during like their time as a student pharmacist?
Probably, yes. I wouldn't see why not. So actually one of the things you can do is when you pick your fourth year project, pick something where you don't go into a lab, but actually work with somebody like me, who'll then give you a little bit of experience of what it's like to do that kind of research and inform policy. There are opportunities. I think the Royal Pharmaceutical Society put kind of fellowships or summer placements or that. Just have a look around at what's on offer, or bother people and drop them an email or phone them and say, I'm interested in that. The worst that you're going to get back is a no.
Oh, thank you for that one. And I think another question is, I think this has to do with the pharmacy education that you're talking about. It says, was there any difference in the pre-reg pass rates for those in industry compared to those in like hospital or community?
The numbers are so small that we certainly wouldn't be able to do any stats with that. And then, yeah, so I can't comment.
Yeah.
There's so few of them that do that.
I think, I don't know if this is the same person or two different people, but they both asked like, what was the biggest challenge in your career and what was like your career breaking moment?
Oh, that's an easy question.
They really put you on the spot there. Sorry about that.
I don't know that there are some key moments. So I suppose I came to Manchester, so I qualified as a pharmacist in Germany. I came to Manchester because I really wanted to be a hospital pharmacist and I wanted to learn clinical pharmacy, which really didn't exist in Germany. I didn't want to go as far as the United States, so I thought I'd come to England, and I ended up in Manchester. But actually what I liked the most when I was doing my master's was my project. So it was that research project which really launched me into a research career. Without that, I probably wouldn't have discovered that. Presenting to the Health Select Committee along representatives from the Royal Pharmaceutical Society and the BMA, sitting next to them when actually, if you look at the dates, I was a lot younger than I am now, was really quite an exciting moment. I was also invited to a dinner at the House of Commons with representatives from the pharmaceutical industry who, interestingly, when I turned up to this dinner, there was also a consultant doctor who was going to talk about charges. And when I turned up, and as I said, this is a few years ago, they thought I was one of the girls serving the blokes, or the men, who were there with drinks and canapes. They did not talk to me at all until I sat down at the table and they realised I was one of the speakers. So that was another interesting moment. And then, yeah, I suppose when I changed from being a researcher, I was for 10 years just doing research, to actually becoming also a teacher, a lecturer, and realising that I quite like doing that as well. I quite like working with students.
That was actually quite interesting. I think especially like if you're at the start of your career and you go through stuff like that, it's quite an eye-opening experience. And I think I'm just gonna put these two questions together. One of them asks about like the salary ranges of like working within policymaking, which I guess is the realistic side of like what the career can give you financially. And another one is someone saying if they aspire, I think just aspiring to get into research after like being a qualified pharmacist, like how would they start planning their career to going into that like direction?
Okay, one of them is salaries, and I think I might leave that to the next speaker to answer around policymaking, because I'm not a policymaker, I'm a researcher. And actually, if you want to get rich, don't work in universities, work somewhere else. Yep, it's not all that bad, but actually it's not all that great either. But it's probably, I can't comment on the policy making salaries. I think how long's a piece of string, it can be, it's probably a massive range. And remind me what the other question was?
I think the other question was about someone who's just like a recently qualified pharmacist, and how would they direct their career route like towards that direction?
Okay, so like I say, to get into research, you need to do a PhD, really, if you're serious about it. However, I would recommend to everybody to actually start with a master's, either an MSc where you get, you know, in clinical pharmacy, where you do part research, or one which is a Master of Research or Master of Clinical Research, where you learn research skills, because in the pharmacy degree you don't really learn an awful lot about the types of methods that we use in the research to do the kinds of things that I do, and you really want to try out whether you like it before you commit yourself to at least 3 years of PhD study, and you then come ready with the skills and the methods already. Does that make sense?
Yeah, I think someone else also asked a similar question of like, if they're interested into research, but they're not really sure if they want to get into that route, like how would they do it? And
do your masters, your MPharm project, do a practice project, don't go into a lab.
fair enough. I think we've got like 2 questions here that are quite similar. One is like, what would be like a big reason for pharmacists choosing to like leave the profession? And when you're talking about like the education side of like the pre-reg like pharmacy, how like it was quite worrying because there were like some factors that would lead to like students not performing as well. So like, do you have any suggestions as to like what students could do during their pre-reg years to like maximize their chances of like passing?
Okay, I think it's being proactive, kind of looking at everything as an opportunity and thinking, oh, I'll do that because I might learn, or that's interesting, and just looking at it in a positive way and thinking that everything that you're experiencing helps your learning, rather than thinking, oh, I've got to do that, or I'll try not to do this. I think more and more, not just because of the research that we've done, but other people, and you know, the Royal Pharmaceutical Society, all sorts of bodies are involved in recognising that pre-registration trainees and people who recently qualified need support, which is why I mentioned these concepts of people and roles that are that you hear a lot more about.
Oh, sorry. I think I can't really hear you. I think there might be a technical. Oh, oh yeah, sound is gone. I think, would it be all right with you, as I'm a bit conscious of time, if the next speaker starts, and if anyone has like any other questions, you could just type it out. Yeah, thank you. So Aditya, I'll just give you the floor, whenever you're ready.
Great. Yeah. Can everyone hear me fine?
Yeah.
Thank you, Ellen. That was a fantastic presentation. Really, even who's been in Policymaking, I learned a lot about seeing the research side of things. So thank you so much for that. So those of you who don't know me, my name is Aditya Agarwal. Most important thing is my Twitter is in my name, which is Chai with Aditya. And I'm a pharmacist. I qualified in 2017, did my pre-reg in community. And I've always been kind of against the grain, if you like, in pharmacy. And I'll talk you through why. Let me just get my presentation up. Share screen. Where we at? There we are. Share. And Here we are. So, right now I'm a relationship manager working in NHS England and NHS Improvement, where as a relationship manager, I'm leading the national project on lipid management. So with a specific focus, because as you might know from your studies, lipid management is actually quite a broad topic, because it covers things like diabetes, it covers other things, but in my case, we're covering specifically high cholesterol, so hypercholesterolemia. So this is so I'm going to talk to you in this talk about my career to date, and also give some indication of other and my experiences and things that can help you. So just to let you know, obviously anything I say in this talk is me in my personal capacity and not representative of my employer or the organizations I work with. I do work with a couple of organizations, and I will touch on them later. So what I plan to cover. I'm going to try and keep this short and sweet. So first bit, I'll give a little brief description about my career path to date. Then I'll talk to you about, what is policy from my perspective, because I know Ellen gave you from an academic research perspective. I'm going to give you from a policy maker's perspective, what is policy. And then I'm going to talk a little bit about what is pharmacy policy versus wider health policy, because policy is such a broad topic, and you're obviously going to be training to become pharmacists. But there is a difference between the policy pharmacy that's in pharmacy, and there's a lot of stuff that Ellen talked about, and then wider policy of the NHS and healthcare system. And then I'll talk to you, and then I will talk a little bit about key decisions that I had to come to terms with, or key things that I had to come to terms with in my career, and we'll come on to that later. So a little about me. Those of you know me, I don't like too many words on a page, because quite frankly, it's not, I feel like I try and add a lot more through conversation. So nice picture slide. So a little bit about me. So I started a degree, well, actually I started out and I didn't know what to do. Should I do pharmacy? Should I not? And in the end, I was working in community pharmacy at the time. And so I thought, why not do pharmacy? And I suppose it's also another element of it is a lot of my family, my dad's a pharmacist, so kind of been, pharmacy's in my blood. And I think the thinking at that time was, whatever I choose to do in life, there's always pharmacy to fall back on. And I think the other element was I met two people who were PhDs, so they've both done PhD in pharmacy, but they're doing very different things. One was, had worked in industry and then came back into community because she had kids, and then the husband, he was a financial analyst in the city. And I realized actually you can do a lot more with pharmacy than what meets the eye. And so I started my degree in East Anglia in 2012. And then over the 4 years, did my degree, did my MSc project. And then during that time, I founded something called the Alternative Pharmacy Careers Conference, which took place in in January 2015. And the idea of that was I wanted to showcase to people what career opportunities there are in pharmacy. And I went beyond, going beyond hospital and community. And I talked a lot about, we had talks from people in various industries, so health economics or in management consultancy. At that point, GP pharmacy was just starting out as a national program in NHS England, so Ravi Sharma, so to speak. And it was a really successful conference, and I learned a lot from doing that, setting up my own thing. I then went and did my pre-reg in community pharmacy, and that's the picture on the bottom left. And lo and behold, I wrote a piece for Health Education England at that time. What does a community pharmacy pre-reg student do? And what is the capability of a community pharmacist? And that was me in the pharmacy during my training. That picture, I had just come back from holiday. I had just done the pre-reg exam the week before, and lo and behold, the photographer turned up. So there we go. Then I realized, well, I enjoy pharmacy, but pharmacy, I always had an inkling it wasn't for me. And if I looked back at what I enjoyed at uni, I really enjoyed the law aspects of pharmacy. And and the service design and the, creating things. And so I applied during my pre-reg year for the NHS Graduate Management Training Scheme. And there was a new stream there called Policy and Strategy. I thought, fantastic, this is what I want. So went for it and got it. And just to be clear, you had to sit online tests, 5 online tests with an application form. Then you have a face-to-face interview with 3 people and me. And then I had a whole day assessment center where I got quizzed on a lot. And you get put in various scenarios and you have to respond to them. So yeah, I go through all of that, and then I got offered a place. And then, over those, I did 4 rotations over 2 years. And, I did the first one in NHS England, then went to a mental health trust. And you don't need to be a pharmacist to do this. So me being a pharmacist actually was a unique thing. Most people who did the graduate scheme was like any other graduate scheme. It's anybody from any degree can apply. My cohort just happened to be that year, it's a really odd year, was majority were Oxbridge and some from Imperial, and then there's me from East Anglia, waving the flag. So, but it was a really interesting experience, and I was able to work for 6 weeks in the Cabinet Office in government, as in the Prime Minister's implementation unit, which was really fascinating as a civil servant, and get a real taste into how do they see health from a very different perspective that the Department of Health sees health, and which is even more different to say the way the NHS sees health. After that, I secured a role at NHS England, and this is my 2nd role in the organisation now. And right now, I'm leading a national programme on lipids, as I mentioned earlier, and I've had an opportunity to do a lot of things in it, including policy making. So recently, we looked at how we inputted into our policy a major policy, submitted some wording, that supports our work, and that has been a really fascinating experience. So I suppose the question is, what is policy? Everyone talks about policy, everyone says they do policy, but what actually is policy? I thought the best way to describe it is through a problem. I'll get a fictitious problem. So, there might be similarities to what's going on at the moment, but this is completely all made up, and I just made this up. So the problem is you want to reduce obesity across England. So how do you do that? Well, first we have to set the vision. So what is the vision? To improve the health of the nation by reducing the impact of obesity on the NHS. Because that obesity can cause a large number of things. For example, cause diabetes, it can cause type 2 diabetes, and it can cause all the other various problems that come to mind. And so you want to reduce that impact of hospitalization in the NHS. So the strategy is the big picture of how you're actually going to achieve this. So, you look at what are all the ways that we can achieve this, what are the various different policy ideas that come, and a lot of them can be informed from, say, Ellen's work in research, in policy research. What are the ways that we can solve, or how do we solve these problems? But then take it another step down. Policy is, if you think about it, it's an arc to get from A to B. And then there's lots of little lines like a clock. And then those are the different policy questions you've got to answer in order to achieve the end goal. For example, in this case, you might have the strategy, how do we incentivize people? How do we disincentivize people from sugar, which is a major cause for causing obesity? Well, one way is the sugar tax, which we obviously know has happened, but how does that work? To devise a policy like that, as Ellen said, you need to work as part of a large team. So if I was a policymaker in that situation, I'd be bringing together the academic researchers who understand the area from an academic perspective. I'd also be bringing, a wide variety of healthcare professionals. So, cardiovascular, lipidologists. I'd also want to bring cardiovascular pharmacists, consultant pharmacists, and as well as all the other specialties associated. I also want to bring, however, because it's money involving, I'd have to bring the Treasury involved, and I'd also want to bring all the other various parties. And then and this is the hard part, you've got to get concordance across all. groups in order to get the policy through, and that is a very, very long and very arduous process. And it's a lot about relationships as well as identifying, that every decision that gets made in a government has one, but it also has an impact somewhere else. And so it's about trying to get things to work. And it's and if you think about the function of government is so huge, then you can imagine the impact something like a sugar tax can have. But that's one element of the policy in this question. But if you look at it from a slightly different perspective, specifically pharmacy policy, well, there might be a consideration of how should we change certain medicines from POMs to Ps to improve their access to patients, so that it improves their lifestyle, if you like. Should we also be providing training to community pharmacy, provide more effective lifestyle advice and motivational interviewing? These are all specific to pharmacy, and the sort of people who'd be answering this sort of question would be people who are pharmacists, who'd be advising on the policy. So as you can see, policy is so much of it, and there's many different ways to input into that overall policy. And the key aim and the key problem that I would have as a policymaker, and this is knowing who are the right stakeholders to bring around the table, and knowing, and understanding how much weight. Everyone has argument has weight, but which point is more important than another one, because at the end of the day, you need to be able to justify the policy, and that is value for money to the taxpayer. So what is pharmacy policy versus wider health policy? So pharmacy policy, I think Ellen touched on elements from an academic perspective, but from a policymaker perspective in a public organization, it can be anything to do with medicines. I'll just give a couple of examples there. Controlled medicine policy, MHRA regulation policy. You can also do work within the Department of Health on community pharmacy, or within the NHS on community pharmacy. There's so much, and they're specifically to do with pharmacy. But if you're a pharmacist and you want to work in these areas, there are specific roles. For example, at the MHRA, they want pharmaceutical people to do certain bits of policy. And so you can go down the route of becoming a pharmacy advisor in NHS England, or a chief pharmaceutical officer in a trust, for example. They do a lot of policy making. But to get to that position, it's not just, you need to be a pharmacist. You have to have practice as a pharmacist for a while, be experienced, and then you're able to move into these roles because of your experience or because of your knowledge from working in pharmacy. So it depends on what policy you're thinking about. Are you thinking about policy as a pharmacist, or are you thinking about just general health policy? Remember, you can go from pharmacy policy or policy of the pharmacist to wider health policy, but you can't really necessarily go the other way unless you're a pharmacist and have been a pharmacist. The other element, as I said, is wider health policy, and this can be anything, not anything except to do with medicines. For example, how do you ensure that hospitals or trusts are, what punishment penalties do you implement in order, if they're not hitting if they're running a deficit year on year? Just to come up with an example like that, that's not true, but or in my case, how can I incentivize primary care to use the new Nightingale's clinical pathways I've got, which is my work? And so there is other elements of policy. Now that's not, although that's primary care policy, that's not pharmacy policy specifically. And so that's how I've been able to work on that. And so there are different career options. So you can be a policy advisor at the Department of Health or within NHS England, and there are many roles generally that just require policy making. I think the way to understand that is to look at the job descriptions. And I know there was a question about salaries. Now, they can go from band 7 up. So you can go, from a policy officer, then a band 8A, which is about, in the Department of Health, that would be a grade 7. That's a senior policy advisor or a manager. And then you just work your way up, you can get deputy director of policy or director of policy and strategy, for example. So you know, there is a lot of scope there, but to get there, you have to have experience in other things, and you have to bring something to the role. So if you're a pharmacist and you do like clinical, you know, it might be a consideration, as Ellen said, if you want to work specifically in pharmacy policy, that you build your pharmacy skills and become a specialist in pharmacy, and then consider moving out and doing other things. Because at the end of the day, you know, from my experience, it's quite broad, but anybody can learn the skills. It's a rigorous skill, but anybody can learn the skills. But then also question, do we always need new policies to do things, or do we just need to change the way we do things? So for me, the key decisions I came to terms with when I, oh, hello, that jumped. The key things I came to terms with when I was doing, going through my career is, what does it mean to me to be a pharmacist? So as you know, I jumped out of my career quite early as a pharmacist, although I still do locums every now and then. But what does it, you know, for me, you know, some people say you're not a pharmacist until you've done your band 6 training, or you've done your foundation training, and you're an IP, you've done your clinical diploma. Then you can do what you want. But then I see a pharmacist as, you know, I'm registered with GPHC. That's also for me a definition of what does it mean to be a pharmacist. It also depends, you know, how much you like clinical, because not law isn't for everyone, and you know, policy making can be like that. So how much do you really enjoy law? And that will give you an indication of how much do you actually enjoy policy making. The skills are similar. And so I had to come to a realization, you know, what do I like? Do I like the law? And I think I knew what my answer was for that. And, you know, what sort of person do I genuinely want to be, and how do I realistically achieve this? So, for example, do I see myself going down the route of becoming a chief pharmacist? Unlikely. But do I see going down and becoming a senior manager or something, or a director or something like that in general policy? Maybe. I'd say that's more likely. Right now I'm working in innovation. I really enjoy that. So do I stay in the innovation space? You know, those are the sort of questions. Thank you very much ahead for this. Look forward to answering your questions. The harder the better. And thank you for your attention.
Well, I mean, that was a very interesting presentation. Thank you for that. I think it's quite interesting because seeing that pharmacists can also get into like Department of like Public Health and the NHS upwards, because I feel like, especially with the NHS, we're just usually used to going into like the clinical aspect rather than the administrative part. So if anyone has any questions, or if you're curious about anything career-wise, I've got one. So how do you navigate the politics of handling different stakeholders and getting them on board, and what do you want them to do?
Sure. So right now I manage a stakeholding group of, just trying to think, you know, I've got multiple private organizations. I have a charity, we have clinical people, we have AHSN colleagues, there's another NHSEI individual. So, you know, there's quite a large number of people to manage. I think part of it is it's about relationships. You know, you got to treat people the way you want to be treated. That's the reality of it. And I accept that everyone can have a bad day as well. And so you just, you know, you try and be friendly with everyone, and you try and call, and you make yourself available to them. I see, you know, my job out right now is a relationship manager. And so part of what I do is, you know, I accept calls during the day, no matter what I'm doing, unless I'm in another meeting, or I call people, or I call my colleagues. It's about being a trusted colleague. That's what it is. A trusted colleague who delivers with integrity. And once you can put that together to your team, that speaks volumes. And I find doing, you know, and then the politics in a way just handles itself. Now they're always going to be, there are obviously more complex political situations, like the example I gave about obesity and other work, then I'll just make that situation up. But I know we all know that happened, right? That to bring all that about. It's about that particular one. You know, there's a question of what do ministers want? Because you can only achieve what the minister wants from a government perspective, and so it's about understanding how what does the minister need doing in order to achieve what you want doing. For example, the minister may say, I'm just throwing this out there, I don't know how true this is, but for the example I gave, well, the minister might be against adding any taxes because it's very unpopular with the voters, and you know they're worried about that. And so, okay, so is there something, maybe another tax they can look at to drop, maybe, or in order to put this into place? You know, it's about incentives. So the politics, unfortunately, is why, for example, policy like Ellen's on minor ailments takes so long to go from A to B. She says sometimes, you know, I think stars have to align, but I think the politics of handling different stakeholders, I think just be a good person and just show that you actually are enthusiastic and passionate about what you do, and you are patient-centered, and I think the rest takes care of itself.
It's quite interesting. The answer was like much simpler than we'd expect.
But it is, though, because, you know, politics is another word for influence. So if you can get politics, and to have influence, you've got to have relationships.
Yeah, I guess, I mean, you make a point. We've also got a couple of other questions. I think these two questions are just about your personal like degree and career route, which was like, what did you do for your master's degree, and like what was your business case at uni, and did you win the prize? And also about your pre-reg year. It's a lot of personal questions.
Don't worry, I did say I want hard questions. I think, you know, it helps people place things. So first question was about, which one again? Sorry, my master's. So I'm doing my master's right now, and you don't need to do a master's to do health policy generally, but it does help. I think so. You can't get too high. I say too high, I probably won't be able to progress maybe the next band or 2 bands higher unless I've got a solid master's in something. Now, I didn't do a clinical diploma because the clinical diploma for me wasn't for me, you know, and I've seen what's covered in it. It's just, you know, I might do it at some point, might do a diploma because I think I want to now improve my clinical knowledge when I've got all the policy out of my system. But at the moment, you know, I feel that's, you know, maybe not yet, but I feel that, you know, so I'm doing my health policy masters right now from Imperial, and it was partly funded by the NHS because when I was on the NHS graduate management training scheme, they funded me to do the diploma, and you get funded for that and to do the masters I've topped up myself. The problem was there was something really, I was meant to have finished it in November. It got extended, but unfortunately something came along, I've been with the COVID. And as a result, we all got redeployed. So I got redeployed to government, actually, into the Department of Health, and I had to become a pharmacist again. And I just did it. But, you know, in a way, that's a good thing because I had the skills already. So, yeah, so I've had to put my master's back a year currently. And if you are interested, it's on looking at artificial intelligence in community pharmacy.
Oh, thank you very much. That's quite interesting. Again, I think COVID has impacted all of us in a very annoying way. And I think the next question is, how hard is it to move like between like different sectors to a higher role in policy making?
Can you qualify the term across sectors? Do you mean like different teams, or do you mean changing from being a pharmacist to something I do?
I'm not really sure because I think that's literally what they've written, but I guess I'm guessing maybe like different teams or like maybe different projects.
Sure. So I suppose it's in NHS England where I work, it's a bit easier to move across because people don't look at you're from this team, therefore only. They also look at the quality of the candidate. I mean, I like to say that. I mean, I've been fortunate that I know these things do exist everywhere, right? But I've always been lucky in that people always look at the quality of the candidate and go from there. So, I mean, I'm here right now. in the future, after this, what would I do? Will I go and work in the AI team because I work in the innovation teams as an AI team. I might go do a bit of work in the AI team, or do I go into hospitals and go and learn the trade of what is an operational manager and really understand the NHS from an operational perspective, because that is what the NHS is. It's providing patient care in hospitals. You know, I'm not saying it's not community pharmacy or that, but the crux of what the NHS is providing care for patients in hospital. And so I want to really understand that. So you might find if you're moving from a pharmacist role to a policy-making role, having experience of policy-making as a pharmacist will be important, whether that be someone like, you know, how many trusts have redo the controlled drugs policy, or how many trusts, you know, they're not even redo, but they amend certain policies. You know, having a insight and the proactiveness to look at that and understand what it is and what it should be, and then going through the process of, you know, speaking to your chief pharmacist, deputy chief to make that change will speak volumes and give you experience that you need.
It's quite interesting. Thank you for that. And I think a lot of the questions that I'm seeing at the moment are regards to how do you know whether you should pick between policy and law, or like experience wise, how much experience would you need to get into the sector? And I think around, do you need a PhD or a master's, or can you get in without any? Like, I think there's just confusion about the experience and the like further degrees of it.
Sure. So if you're talking about education wise, okay, so you've heard today from two very different speakers, if you know way. You've heard from Ellen, who talked about it from the research academic perspective. And for that sort of role, and correct me if I'm wrong, Ellen, in this, but you need to, it's preferable to have, or it's highly wanted in a way to have a PhD in a way, alongside a master, and you have a master's as well in your specialty. But for what I do, you don't need to, but at some point you're going to have to do a master's to progress in your career. And so in a way, you don't always need to, you know, so that's why. And I've just chosen to do health policy because that's an area I like. And I've learned a lot, you know, for the MSc. I don't have to put this in the diplomatic way, but I've actually really enjoyed my MSc. There's, you know, the way the lecturing, the talk, the speakers, you know, my dissertation supervisor, and I've got two. One of them, I think, is one of the smartest people I've ever met, you know, and the energy that gives off for me in the area is just fascinating, you know. So I'm passionate about the area, which is why I've gone into this area. Ellen, did you want to add anything about education?
I was just going to add something to doing masters, and I'm really glad that you talk about it very positively and enthusiastically, because at first you said you just have to do a master's because in order to progress in your career, which sounds a bit more, oh yeah, I've got to do it, but I actually don't want to. A master's, if you find the right topic, you know, you have taught programs. So if it's clinical pharmacy, you're very focused on therapeutics and the clinical topics, but you also, if you take it to a full master's, learn a bit about research, and you do a small project, or like you do around health policy. What a master's does is that it takes your learning and the way that you think about problems and issues to a different level. It teaches you at a more advanced level than the MPharm degree to analyze problems critically, think about the evidence and what's out there to inform your decisions. So it gives you a whole load of skills that do really help you to do those kinds of jobs. It gives you that critical perspective on things, and it doesn't just have to be policy making. It's also, as a clinician, the way that you approach thinking about and treating a patient takes you to a different level. So a master's really isn't just about learning a bit of research. It's quite a rounded degree that gives you a whole load of very valuable skills.
I would completely echo what Ellen said. I would completely echo the point about the way the master's is structured. I went into my master's thinking, not sure what to make of this, because for me, university was very, you know, they tried different techniques, but I'm a very much more like I don't mind people. I like, it's really weird. I need to hear a topic, understand it, and then write it down how I understand it, then go to the next bit. Sometimes lectures aren't like that unless they're recorded. Then when they became recorded, that was fantastic for me. I was able to really understand bit by bit. But sometimes when in class, sometimes I found, but then in my MSc, the style of that changed. It wasn't, you're actually, I'll read the bit well before. I learned that from you, not doing it the first time. You'd read the topic, understand the foundation, go to the talk. We had the specialist who talked for half an hour, and then the rest of the half hour would be, you can throw absolutely any question in the world at them. And it was a much, much more rounded experience. But I think to get to that point, you have to understand the degree process first. You can't just jump into that, doing that as a master's. I think you have to go through the undergrad, understand that, and then jump into and then when you're ready, I think is the right point, then do a master's when you feel ready, academically ready for it.
That was a very interesting response from both of you guys. I think it does put masters in a different perspective. And I think the other questions mainly do ask about like, how would you find jobs that are like about like policy making, like how do you actually like search for jobs in that? And also I think experience wise, like how much experience do you need? Can you get into policy making right after your pre-reg? Because I think it's interesting. I'm guessing for like a lot of attendees, including myself, to like actually get into the career of like being a policymaker, especially for pharmacy. But it's more of a like, how do we get there? What experiences do we need, or how much experience do we need?
Sure. That's an interesting one. So I suppose what came into my mind when you asked that question, so is that what I do, I'm not the first pharmacist to go into the civil service or any of that kind. There is actually an article in the Pharmaceutical Journal going back years, we're talking years, of a pharmacist working in private office for a minister. I can't remember, I remember reading it, and it's on the Pharmaceutical Journal online, you'll be able to find it. But so what I'm saying by that is if that individual gentleman was able to do, I think it was a guy, he was able to do that then, we can still do that now if you feel like, if you want to make that move. For civil service jobs, you just go to, as I said, civil service jobs.gov.uk, I think it is. Have a look there, and you might not be able to get a job now. You might need to, but there are, if you want to jump into policy making straight after your pre-reg, if that's, you feel that's right for you, I would apply during a pre-reg year for something called the Civil Service Fast Stream, which is the civil service one, and that's all policy making. There's a specific Department of Health one, or you can come to the one I did, which is the NHS Graduate Management Scheme, if that's what you feel. I would also recommend, if you want to get some experience, your universities run studentships in the summer. Yeah, I'm sure in pharmacy practice, why not get your hand in that? It's not, you're doing research that informs policy, which is part of the whole policy process. So that is another way in. If you want to go volunteer at a charity who does health policy, say, I want to learn, I'm a pharmacy student, I want to learn about health policy. And the charity can be anything, and it'd be better if it's an area you're passionate about, whether that be an area of mental health, or whether that be cardiovascular disease, for just saying, because that's what I work in, or whatever it is. Just find and just go and do that. And I think you will get a taste of whether you like this and whether you don't. Also, you'll understand, you see, the difference is there's different kinds of policy making. For example, I do public policy making, and then does academic policy making. The charity option is more public affairs policy making. So it's all very different kinds of policy making, and all used in a way to inform or lobby, depending on which organization, a certain outcome.
Yeah, it's actually quite interesting. I think for a lot of us, we didn't really know about like the programs that you can get into after that, because it's just more of a pre-reg student blur, and then you're in the policymaking sector, whichever one you choose.
No, like, so policymaking, it's not, you don't just apply for a job for a policymaker, it's, I think there is, without put too fine a point on it, there is a level of, I think, experience that you need as just in the system to do policy making, because you need to be able to rigorously dissect the wording that you're looking at. So I don't, without giving anything away, but I recently I got my entire working group to input into a policy decision just the other day. And we, having to go back and through emails, and I had to go through 2 committee meetings, we had to rush through this, but we managed to get it done. But I had to think about the different, incentives and the asks. So, this group wants this group would want this, but how do I get this group to work with, to align with this group? What's the neutral wording I can use? Things like that. But you only get that from experience of having worked with different groups. So don't be too key. As I said in my talk, anybody can do policy making. What you need to be a successful policy maker is experience in fields outside of policy making. I think that is what I would say it makes a good policy maker.
Well, thank you very much.
Can I just add to that? That's a really important point, that get some experience, because actually you can't make policy if you don't understand the context and you don't understand the needs of the people and the organizations within which and with which you would want to work and make policy for. So experience is just needed, and you're at the beginning of it, and just go for it. And then if you don't like a particular area or sector of work, then apply for something else and try something different. Just, look at opportunities and think, oh, that looks interesting, and get yourself exposed to it. Apply for a role there. It's all experience, different pharmacy sectors, different things, but I think you do need experience, which just means working for a bit, to understand the health system and where pharmacy sits and where medicine sits, and just some time to expose yourself and work within that system will really help you and identify where you want to go.
Sure. Exactly. That's the right point. That's exactly a wicked point. The question here saying, whether I chose policy, whether I knew I enjoyed policy making and law. For me, I think the easiest way to answer that was when I was doing my degree, which did I want to spend more time on? You don't learn policy making. Policy making is an application of knowledge, is the way I put it. But how do I? But the process you do it is through like a law type process, just because of the rigorousness of there, and in my case, where every word can make a difference. So how do you do that? So you have to know that through experience, and you have lots of people working on it for that specific reason. But I would say how I knew about law was, I spent more time studying the law aspect than I studied, say, wider pharmacy practice. That bit just came better for me.
I mean, fair enough. And I think these two are about how you've entered, the general advice you have for grad schemes and how you've entered it. And also I think you talked about how you're working within innovation and the tech side of it, and someone's asked you need to learn programming to work in innovation.
Sure. So the programming one is an easy one. That one, no, basically, because you're thinking of different kind of technology. You're talking your health startups. I work in the NHS, so we don't do, we work with startups. So I don't need to know coding. My job is to run the program. When I say program, we're talking a series of activities in order to achieve an outcome. It is like a project. Think of a bigger project. That's called a program. My job is to run this entire project, this huge project. And so I didn't need to learn programming language to do that. How hard to test that? Enter grad scheme, and what could be your general advice? Okay, so grad scheme tests. I hope you guys like psychometric tests, because you're going to have to do them when you go for oral. And that's pretty much the same for any grad scheme you ever apply for, should you apply for multiple. They all require to do psychometric tests. And so I would, if you're nervous about them, go on YouTube, go online, look up examples of tests, take your time, first of all, to understand the data that's being presented and answering the question right. then stop timing yourself. And I think that's how you'll overcome not your, say, angst for psychometric tests. No one likes them, but they're everywhere. So what are you going to do?
Oh, yeah, I mean, thank you very much. I mean, I understand I'm a third year, and I think I speak for all the other third years. No one's really excited about the Oriole. It can be quite daunting, to be honest. But I guess thank you very much for both speakers. You've been incredibly informative. I think I can say for everyone that we can leave this webinar being more informed about this and how we can enter this career. And if anyone else has any other questions, I guess ask them now before we end the webinar. Now it's just like waiting if anyone else has any questions.
I suppose if I had to leave everyone with one final parting thought, is if you're looking to go into or want to understand more about policy making, speak to your lecturers. Like lecturers do know a lot. You know, they go speak to your lecturers and ask them, how do I want to learn a bit of policy making, or I want to cut my teeth into some, idea generator, whatever it is. Say you want to go into policy making and see what they say, and they're going to give you the same things that Ellen and I have said, which is studentships, get involved in. So one of the things I did at uni was get involved in my pharmacy teaching committee, in the committee that I got in the final year, where as a student representative, you get involved. So I did that. It sounds geeky or nerdy, but that opens up a lot of the way you think of how people actually do problem solving for complex problems and policies that come out of that. Right now I sit on the Royal Pharmaceutical Society's early pharmacy career group, so the ECPAG. I'm a member of that. I don't think I would have got into that position had I got all the other experiences I've got to date. And then being able to, it's a very diverse group. It's a very diverse of things we discuss. We try and discuss things for early career pharmacists and how we can define the RPS knowledge, responses to certain things. But to do that, you have to understand you have to have done some element of policy making and some element of policy making, or have experience of that. And so I would recommend just get stuck into as many opportunities as possible. And I appreciate right now it's super difficult because everyone's locked up. But I would recommend that, once things subside, just try and get stuck in. Maybe right now is an opportune moment to speak to a charity and say, can I get, if you have time, or if you want to do a day a week or something, just get involved with a charity, because I guarantee you there are some charities so encumbered with the amount of work they have. Like I have one on my working group, and I still speak to them, but they say, our capacity is very minimal because we are just so busy dealing with COVID, and they need support. And so if you're an enthusiastic, happy individual who always turns up on time, always bubbly, always, people, you will always be accepted for any experience.
Yeah, thank you for that. I think one thing that I also remembered while you were talking about experience in university is that I think most universities have societies that are dedicated to policymaking. So you don't need to be a policy, an economic student or some other social science students to actually join. I think that's one thing that I learned this summer, that you can join those societies and form little think tanks that actually focuses on the health aspect or other aspects. So really that's something that you can focus on, try achieving during lockdown, because I can understand that we're all, like you said, we're all locked in. There's really nothing else that we can do.
And if you're political, there's always, depending how political you are, if you wanted that, you could always do some policy making from a political party perspective. It would be a very unique experience, I can give you that. It's because it's a whole different way of policy. Campaigning is also a type of policy, believe it or not. It's a lobbying for policy change. So that's only if you're super passionate about this, a particular area or something.
Well, thank you very much. I think one last question would be, can they access the slides for reference? The slides that you guys both gave? Yeah. Well, there you have it. Thank you all for attending. Thank you very much to both speakers for giving your time to educating like our members, helping out students. I'm sure we all really appreciated all the advice and all the knowledge that you gave us this evening. And I guess that is it. Thank you for attending this webinar Wednesday, and thank you guys again for helping me host it.
Thank you for coming along and listening and engaging.
Yeah, of course. Thank you so much. Thank you for all the amazing questions for both Ellen and I. They were fantastic.
Yeah.